of partners actually said they felt helpless. They didn't know how to help, and 28% of partners said that arguments between them and their loved one were initiated because of menopausal symptoms. So you would think then, if there's all of these concerns happening, that there'd be a lot of women seeking healthcare. But in actual fact, and now you've got to bear in mind this study was done in 2016, I actually do think things have changed dramatically in the last 5 years. So I don't think we get the same results now. I think more women are seeking help. But back in 2016, which isn't that long ago, only 50% of women had actually seen a health practitioner of any kind to discuss menopausal symptoms. And that was despite the fact that 22% of them had sleeping problems, 20% had difficulty with memory and concentration, nearly 80% had flushes and sweats, and 36% said that the menopause symptoms impacted their social life. So it's interesting, isn't it, that even though they all felt dreadful, back in 2016 anyway, they weren't seeking help. So why don't women ask for help? Because women are generally really good at asking for help and really good at going to health practitioners usually, and especially for their children. You know, they'll take their children to see all number of people to try and help them. And I've heard things, you know, in my room, and this is a sort of a summary of some of the things I've heard in my room. One of the big things is I think women are sandwiched between their parents and their children, and so they're just spending all their time looking after everybody else. And my message, you know, if there's 3 learning points from today, one of the learning points would be that at this time of your life, you need to come first, at least for some proportion of the time. Women are tough. I think a lot of women honestly believe that they should just tough it out. They should be tough. They gave birth, you know, women are not supposed to actually have difficulty with things. They're supposed to just be able to be tough and kind of soldier on and get on with it. Women should be able to fix themselves. Somehow we've been taught to believe this, that, you know, that you need to be able to fix it yourself, and if you can't, you're weak. This is just a natural part of life. Oh my goodness, my internals just scream when people say this to me. This is just a natural part of life. I should be able to cope with this. I mean, childbirth's a natural part of life too, but, you know, it's painful. Why should you be able to cope with it just because it's natural? And then the other one is hormone therapy gives you breast cancer, doesn't it? And this is a big reason why women didn't come, because they thought, well, what's the point of me going and seeing someone? I'm going to get breast cancer if I take hormone therapy, so there's no point me actually going in the first place. I think this space is also what's changed in the last sort of 5 to 10 years. So, what is perimenopause and menopause? And this slide says, if you can't read it, just when you get used to PMS, they tell you you've got perimenopause. And the reason I put this slide in is because I often find I almost feel like there needs to be a definition called pre-perimenopause. Because what happens with a lot of women, I find, is that as their periods are still regular, so they don't meet the technical definition of perimenopause of having irregular periods, but their PMS that was always pretty mild is now on steroids. And that tends to be for a few years, and then the periods start becoming irregular, and then they feel like they've got PMS all the time in perimenopause. I've also put the contraception thing in there because I think I don't want you to miss this point. You can get pregnant in perimenopause, and the important point about hormone therapy, it is not contraceptive unless you have a Mirena in as part of the progesterone component of your hormone therapy. So perimenopause is the period of years, on average about 7.4 years, but 5 to 10 years before the final menstrual period. The final menstrual period in Australia and the UK is at 51, usually. But that's the middle of the bell curve, so there are going to be some women coming into their final menstrual period much younger than that, and there's going to be women coming into it much older than that, like me. So the symptoms begin in perimenopause for a lot of women. And in actual fact, perimenopause is often tougher to handle than postmenopause. Because you've often got irregular cycles and sometimes heavy menstrual bleeding, and you've got the menopausal symptoms kicking in already, but you're still bleeding. So it's just it's a bit of a shit show, just quietly, for some women, not everybody. Symptoms start in perimenopause and they may stop at menopause, but they often don't. So for a lot of women, they will extend into menopause for a varying number of years. The average age of bothersome symptoms in menopause is about 5 to 7. So each woman is different. 20% of women will not have any symptoms, and I actually met one of those ladies yesterday. Don't know how she made it into my menopause clinic, but she was there. And she had no symptoms, nothing. And I never meet them, but 1 in 5 apparently are like this. The important thing to understand is the definitions of early menopause and premature menopause, because I meet women all the time who have had one of those two things and no one put them on hormone therapy. These women need hormone therapy until the average age of menopause. So the definition of premature menopause is the final menstrual period occurring before the age of 40. And the definition of early menopause is the final menstrual period occurring before the age of 45. So if you're a 43-year-old woman and you've had your final menstrual period, you need to be taking hormones until at least 51. Because you are at risk from the diseases that hormone therapy helps prevent, because you don't have the natural levels of estrogen that your girlfriends have. Your girlfriends have got estrogen in their corner up until 51 on average, whereas you've lost yours at 43. So a lot of those women have been missed because of all the scares about hormone therapy, and those women really need hormone therapy. It's not even a hormone replacement, it's hormone replacement therapy in the true sense of the word for those women. They actually need the hormones to be replaced. So, before I go into the symptoms, I just thought I'd remind you what happens in your menstrual cycle. And I know I might be telling you how to suck eggs here, but sometimes it's useful to just understand what's happening with the hormones in a normal menstrual cycle. Now, this is assuming the normal menstrual cycle is 28 days long, which we all know is not the case, okay? So just imagine a 28-day menstrual cycle for the purposes of this discussion. So on this axis we have the estrogen levels, and you can see that the green line that the average estrogen level is 400 throughout a menstrual cycle. And this is in a pre-menopausal woman. When she is post-menopausal, her average estradiol level is 20. So that is 5% of what she was previously, travelling with. Which is why these women with premature and early menopause need to be given hormone therapy. So what happens is that in the first half of the cycle, the egg matures and grows and releases the estrogen. And so you get your estrogen rising in the first half of the cycle and then peaking just before ovulation. You can see that at ovulation, estrogen levels plummet. This is why many women with menstrual migraine will get migraine mid-cycle and before their period. Because if you look at what estrogen does, it drops those two different points. Once the egg is released, the corpus luteum, which is the leftover part of the follicle, then produces progesterone. So the progesterone is low in the first half of the cycle, as you can see, and this is when women feel pretty good because they've proportionally got more estrogen than progesterone. Then progesterone rises. You can see that it peaks about a week before the menstrual cycle and then starts coming down again, and the estrogen does a bit of a slower sort of peak. But you can see that you're proportionally more progesterone than estrogen in the second half of the cycle. The women that get severe PMS or premenstrual dysphoric disorder they are the ones that are reacting to that natural progesterone in their cycle. And so that's why all of that kind of PMS, the physical and the emotional symptoms happen in that second half of the cycle. So that's just a little bit of a idea about what happens with the hormones. So, what are the symptoms of menopause? Now this slide doesn't have all of them, but it has a lot of the prominent ones. So dry, itchy skin, bitchy, mood issues, sweaty, sleepy, bloated, forgetful and psycho. So I think the prominent things that are missing from here are migraines for some women, joint symptoms, genitourinary symptoms. They're probably the main ones that are missing. And I actually think it's a good idea to, if you're struggling to get your doctor to believe or understand that you've got perimenopause or menopause, if you do one of these symptom scales, this one's from Jean Hales, but you can get it from the Australasian Menopause Society website, you can get it from the Jean Hales website, and you come in and you give that to the doctor and say, look, I think I've got perimenopause, then it might help, because some doctors are actually getting boned up on this, but a lot of doctors don't have very good information about menopause and perimenopause. They haven't been taught. The Women's Health Initiative study actually meant that a whole generation of doctors didn't learn anything about menopause, and certainly nothing positive anyway. So if you do that, sometimes that will help get that conversation started and get them to take things a bit more seriously and make them realise that you know what you're talking about. You shouldn't have to do this, I agree, but I'm trying to help you sort of have some tips on how to kind of get the whole thing rolling. So I'm just going to go through my experience of treating many thousands of women with menopause, and some of the things that are myths or forgotten or not really understood. So when I first started, I thought women would be coming to talk to me about their flushes and sweats. That's what I thought people would come and tell me. And they do. I mean, as we saw in the survey, 80% of women do have flushes and sweats. But when you ask women, it's actually not that much bothersome to them, flushes and sweats. For some it is. There are some women, there's a class that have very severe hot flushes and sweats, and they definitely are bothered. But the majority of women have them, but they're not too bothered by them. What actually bothers them is the neurocognitive effects of the hormonal changes. And so, as this slide says, I'm afraid my brain has left for the day. Some women don't get any flushes and sweats at all, but they get a lot of this, a lot of cognitive dysfunction and brain fog. They suddenly start feeling like they can't function in their workplace. Things they used to be able to do with ease, they just can't do anymore. They're having trouble multitasking, they're having trouble concentrating. They're worried. A lot of women are worried that someone's going to notice that they're not actually functioning very well, and they might even lose their job. And I've had patients who've actually sadly left their career because of this, because they didn't get any help and they just felt they had to just leave. And some of them have gone on to do a job that's just easy and they don't have to think about it much. It doesn't matter if they make a mistake. But women should not have to leave their jobs, and often they've spent their whole career getting to that point, and now they're leaving. It's ridiculous. Self-esteem and feeling oneself, I think, is that cognitive thing too. A lot of women tell me, I just don't actually feel like myself. I just feel that they often find it hard to actually put it into words. But I really feel that is all to do with the brain effects of lack of estrogen on the brain. And then there's the mood. Women get really upset by being moody all the time, particularly because it impacts their children and their partner. And women don't like thinking of themselves as being moody, they like thinking of themselves as being calm and nice. So this can be really, really upsetting. Really upsetting. And so the big question, the $6 million question, does this woman need antidepressants? Or does she need hormone therapy, exercise, sleep and support? Not necessarily in that order. And I meet women every day who have been put on antidepressants in perimenopause. They've never had an episode of depression in their life before, but they've still been put on antidepressants. Now, there are some women that clearly need antidepressants, and some women who have had mental health issues throughout their life will find that when they come into perimenopause, they get exacerbated. So if they've got an existing anxiety disorder or depressive disorder, that hormonal turmoil that happens in perimenopause is going to exacerbate that. But for women who have never had any mental health issues and suddenly now start being depressed, anxious, moody, sometimes it's not the first step, and they'll often get side effects from antidepressants, and they don't really want to take them anyway. Most of them say to me, I know I'm not depressed. They know they're not depressed, but they also know that they're not right. So I would be encouraging perhaps that approach first, and then if you need to add in antidepressants, you've always got that option down the track. The other big elephant in the room, weight and body image changes. And I think this impacts on mood a lot too. Women, that whole thing of not feeling like yourself, you're also feeling kind of physically not like yourself as well. You know, you're bigger, you're starting to put weight on around the midriff area. And there's huge numbers of reasons for this. Estrogen is an inflammatory regulator. So it's an anti-inflammatory in a way. And a lot of these things are because of inflammation. There's increased visceral fat deposition, particularly around the belly. There's loss of muscle mass, which is called sarcopenia. The loss of muscle mass leads to a lower metabolism. That reduces insulin sensitivity. And then there's secondary factors, like just being tired all the time, you know, not sleeping well, that rises cortisol. Cortisol leads to weight gain. Can't be bothered. If I had $1 for every woman that told me she can't be bothered, I'd be Donald Trump. I'd be rich. So mood, motivation, so there's a whole lot of, so weight gain at menopause is very, very multifactorial, that's what I'm trying to say. And it's not an easy fix. But sometimes hormone therapy can start making people feel a bit better, and then they start doing other things that then lead to these things improving. And I've definitely seen that. Excuse me. The other thing that no one wants to talk about is vaginal dryness, because it's not a very sexy topic. Not everybody gets vaginal dryness, and it tends to be a later symptom. So it tends to be a sort of a late peri or post-menopause symptom, if it comes. Once you get vaginal dryness, it never goes away. So whereas your menopausal symptoms, your other menopausal symptoms that we've been talking about, you know, the average of 5 to 7 years of them, and then they sort of just go. Vaginal dryness, unfortunately, and the genitourinary syndrome of menopause, which is what the Americans like to talk, they call it, this is an American term, and they made the whole world say that because they don't want to say the word vagina. Anyway, you can get recurrent urinary tract infections, urgency, incontinence, so the bladder is actually also an estrogen-dependent tissue. And when women take hormone therapy, about 60% of them will respond vaginally. They'll get good vaginal response and bladder response, but about 40% won't. And so those women, if they're bothered, may need vaginal estrogen. Vaginal estrogen is extremely safe, and it can be used in women with breast cancer. And a lot of women don't realise that. So they're suffering, and they could be just taking vaginal estrogen. Vaginal estrogen just works in the vagina. There's very little absorption into the circulation.
Yep, great stuff.
Just briefly, another thing is skin and hair. There's a lot of hair changes at menopause, which contribute again. This is all, you can see how it all combines to contribute to this feeling of just not being yourself. So now, not only are you putting weight on around your abdomen, feeling like you can't function normally in your brain, but you're losing the hair on the top of your head as well, or your skin's changing. Estrogen is very good for skin. I know there's a trend on social media about putting estrogen on your face from vaginal estrogen. Please be careful about some of the stuff that's on social media. It's not evidence-based or research. It doesn't mean it might do harm necessarily, but yeah, I've checked this out with the local dermatologists about whether there's any actual evidence for estrogen on the face, and they have told me no. So until I see a study where they've actually studied it, women putting their vaginal estrogen on their face.
It's TikTok.
No, you'd think it's funny, but I had a patient and I put her on vaginal estrogen, and 3 months later I said to her, "How's the vaginal dryness going?" And she said, "Oh no, it hasn't changed." And I thought, gee, that's weird. I said, "Really? Really? The vaginal estrogen didn't make any difference?" And she went, "Oh no, I've been putting that on my face." I went, right. Migraine in perimenopause can be a nightmare for some women. And the reason for that is, remember the slide that I showed you about the 2 estrogen dips? What happens in perimenopause is we have estrogen doing that. And so we can, in some women who are very susceptible to hormonal migraine, they'll start getting migraines just all over the place. So they won't get it at predictable times in their cycle, it'll be much more frequent. And so quite often the thing that we need to use is hormone therapy and get above that estrogen sort of level so that they don't sort of trigger their migraine. Migraine with aura is not a contraindication to the type of hormone therapy that I use, which is transdermal estrogen, so estrogen through the skin as either a patch or a gel, is fine in migraine with aura. And where progesterone is required, continuous delivery is recommended quite often. So sometimes a Mirena can actually be quite helpful in this situation. Okay, so we've got Thelma and Louise there, and then at 50 or 51, their hormones literally fall off a cliff. It really does. I've put testosterone in brackets there, and the reason I've done that is testosterone is important, but it does not fall off a cliff the way estrogen and progesterone do. Testosterone actually starts reducing gradually from the age of 20, sadly. And it's a slow, gradual reduction across time. It's very important in women who have a premature menopause from ovarian, having their ovaries removed, to give them testosterone, because they will suddenly go from young woman levels of testosterone to no testosterone. But all of us have been experiencing a gradual decline. So that's why I've put in brackets, and I prescribe what I call body identical hormones, and I'll go more into that in a minute. So before I start talking hormones, I just wanted to highlight the importance of lifestyle, and I'm not going to go into it too much because there are other speakers here who are, I'm hoping, going to give you a lot more information about that. But one thing I really feel strongly about is, if you don't want to be that lady who's sleeping on a treadmill, then maybe you do need, even though you would like to manage everything naturally in a good lifestyle, maybe you do need hormone therapy to get you going. And often by the time women come to me, they know that they should be exercising, they know they should be eating well, they know they shouldn't be drinking too much alcohol, they know all of that, but they're so exhausted and worn down and their brain's not working properly and they're not organising their time properly and they're just not able to do all of those things. If they go on to hormone therapy and start feeling like themselves, then what I see is that nearly all those women will choose to do all of the things that are listed there. So sometimes you need actually to take the hormones to feel a bit more normal again in order to be able to do the lifestyle stuff, which is sort of somewhat ironic, I suppose. I suppose we're all taught to think, well, hormones are the last resort. I should do all of these other things first. But I just challenge you to kind of like think, well, maybe the reason I'm not actually doing all those other things the way I would normally is because I just don't feel right. I don't know. But anyway, just food for thought. Protein with each meal. We all know that. My big tip, once you feel you're ready for it, is to lift weights. I can't believe I'm standing here saying it. I can't believe I'm doing it myself now. I can't believe how much of a difference it's made for me personally, but also for my patients. You lift weights and you don't have to go to a gym, work out how to do it. If you don't like gyms, try and work out another way to do it. But you build muscle, and that means when I'm sitting down, which I've got a very sedentary job and I'm talking to people, but if I've gone to the gym that morning and I've lifted the weights, my muscles are metabolising. They're working away while I'm just sitting there in the chair. But I have to say, the surprise to me was mood. There's something about lifting weights and mood. I don't know what it is. But you feel better. You just feel better. So look, if you don't, I so understand gyms. Gyms are not female-friendly environments. I don't like them either. I only go to the group classes because I can't self-motivate to lift weights. But even if you think about how can I do it at home, how can I do it on my own and then progress the weights up? I don't know. Just have a think about it. Complementary therapies I'm going to leave for. I'm not sure if that's what Dr. Dan's going to talk about. But I did want to talk about evidence for CBT for hot flushes. The problem is, I don't know anyone that delivers that kind of CBT. So while it's nice in theory, I don't know where I would send somebody to actually get it. But there has been some very good quality research showing that cognitive behavioural therapy can help flushes. Bioidentical hormones are not recommended by any of the International or Australasian Menopause Society. It's a totally unregulated industry. There's often multiple hormones in the troches. There's often not enough progesterone to protect the lining of the womb. So I think if you're thinking that seems appealing, it would be much better to get body-identical hormones from a doctor, which are on the PBS and are regulated 100%. So, at the risk of looking like I'm advertising these products, I'm not. There are only a few. They are it. So it's not like there's alternatives, millions of alternatives that I'm excluding off the slide. On the left are the patches that nobody can get anymore. If you can get those, you could make yourself a small fortune. The gel is in the middle. There is another brand of gel as well that I haven't got up there. And the only natural progesterone we have is Prometrium, which is a capsule that you take at night before bed. So if you are post-menopausal, then you would take a continuous hormonal regimen, which means that you would have estrogen, and if you've got a womb, progesterone every day, all throughout the month. If you are perimenopausal, you would take what's called a sequential regimen, where you would take estrogen all through the month, and the way to remember that is that it's the estrogen that's doing all of the heavy lifting with your symptoms. And then you would take progesterone for half the month. Now you remember my slide with the progesterone in the second half of the cycle? It's that cyclical progesterone that gives you that monthly withdrawal bleed. At some point you will become postmenopausal. We won't know exactly when, but you'll be able to switch then. If you still need hormone support, you'll be able to switch then to the continuous version. I use a patch or a gel for the estrogen delivery, and that's because there is no increased clot risk if you take estrogen in through the skin, whereas there is a small risk if you take oral estrogen. It's pretty small, but it becomes more significant as women get older. So it's just easier to prescribe estrogen through the skin. We'd love to prescribe progesterone through skin, natural progesterone, but it actually doesn't absorb through skin. That's why it's a capsule that's taken at night before bed. I find it fascinating that you can buy progesterone cream on the internet. I don't understand how that works. Natural progesterone doesn't absorb through skin yet. We haven't got the technology yet. There might be somebody trying to create it, but we haven't got it yet. You can get oral body identical hormones, so there are some women who just don't want to muck around with patches and gels, and they're happy to accept the very small risk of clots and things with oral hormones. You can get body identical oral hormones. Mirena is often a great option, especially in perimenopause, when women have that awful combination of perimenopausal symptoms and erratic heavy menstrual bleeding. Mirena will provide the progesterone component of the hormone therapy, and she'll just have to use a patch or a gel, and then it'll also provide contraception, and it will also control the heavy menstrual bleeding. So that can be a good option for some women. If women don't have a womb, like they've had a hysterectomy for some reason, they don't need to have progesterone. So the progesterone is in the formulation to balance the effect of the estrogen on the lining of the womb. Because estrogen is quite stimulatory to the lining of the womb. So if you give women estrogen alone and you don't give any progesterone, the lining will thicken and thicken up over time. And then you can actually run into trouble with abnormal cells and that sort of thing. So we know we've got to get that balance right. But women that don't have a womb don't need the progesterone. At all. Now, if they've had, there are caveats, it's complicated. If they've had endometriosis, severe endometriosis, I would say yes, they do. Because you don't want to be waking that up with the estrogen. If they've got deposits of endometriosis in their pelvis and you give them the estrogen without the progesterone, it can wake that up. But generally speaking, that would be the main thing. Natural progesterone is quite nice for sleep for some women. It's quite a nerve calmative, like a nervous system calmative, and so some women find that they sleep very well with natural progesterone. Other women don't. I mean, hormones are so different in all different women. I can never predict who's going to do what, but I can only speak in generalities. So, before I go on to safety of hormone therapy, I just wanted to talk about the preventive health benefits of hormone therapy. And this is the thing that people don't talk about when they talk to women about hormones. They just talk about risks of breast cancer and they don't talk about benefits. And this is what I mean about a balanced summation of benefits versus risks. So one of the big benefits is cardiac. As I said before, estrogen is an anti-inflammatory, and this is very, very particularly in the vascular system. So the vascular tree, all of our blood vessels, including the blood vessels of the heart. And there's a timing hypothesis with starting hormone therapy, so that if women get hormone therapy within 10 years of their final menstrual period, or under the age of 60, whichever comes later, then they will get this benefit, this cardiovascular benefit, because they haven't had the chance to accumulate the damage to the lining of their womb, the atherosclerosis or thickening in the blood vessels won't have occurred, and they'll get their estrogen in and it's still doing its thing. Cholesterol profile goes off tap often for a lot of perimenopausal menopausal women, and then it improves with hormone therapy. It reduces the progression of atherosclerosis, and it actually has been shown in clinical trials, including the Women's Health Initiative study, which was the one that everybody got all excited about, that it lowers cardiovascular and all-cause mortality. That's in those young women, not in women who missed out on it and then started it after the age of 60. Bone health is another huge benefit of hormone therapy. So I'm sad to say that the women that missed out on hormone therapy as a result of the Women's Health Initiative findings and the big scare that happened worldwide, most of those women have got osteoporosis now, and I see them every day. So hormone therapy significantly reduces the chance of developing osteoporosis, and it's also used as the treatment for osteoporosis now in younger women. So if a woman gets diagnosed with osteoporosis and she's sort of just over 50, these days the first step would be to give her hormone therapy. That's how good estrogen is for bone. You can see that at menopause there's a 10 to 12% plummet in bone density, so it really happens quite quickly. And at menopause there's a significant increase in vertebral and hip fractures, and it's pretty bad to have a hip fracture at any age, but particularly when you're an elderly person. Having a hip fracture has up to 30%, probably even in some studies up to 50% mortality rate. So it's good to protect your bones, you know. Osteoporosis is painless, so you don't know you've got it. It's like hypertension, I suppose, you know. You've just got to kind of try and prevent it. The third preventive health benefit is potentially dementia. We're still getting a lot of mixed studies in this space. We do know absolutely 100% for sure that if you're a woman who has premature menopause and you don't receive hormone therapy until the average age of menopause, you have a 30% risk of developing dementia compared to your same age friends. So there is clearly, we know the brain is loaded with estrogen receptors. We know that we all get brain fog, so we know there's clearly something going on with estrogen in the brain. There's potentially a reduced risk of Alzheimer's when it started in that early window, but we don't know for sure. And ongoing research was going on in the States. There's a lot of research in the States. I'm not sure if that's been affected by Trump, but it was happening, that we were really trying to get into that, and I don't know if he's wrecked that or not, like he's wrecked everything else. So, safety of hormone therapy. As I said before, oral estrogen does carry with it, and that's the same with the oral contraceptive pill, by the way. It's just that our younger people are younger, so their overall risk of clots is low anyway. So if they have this slightly increased risk, it's not as important as when we kind of get a bit older. But oral estrogen definitely does have a risk, but the transdermal bioidentical estradiol that I prescribe, either patch or gel, there's no increased risk. With stroke and cardiovascular disease, there was some extra risk shown in older women. So that Women's Health Initiative study, it was the average age of women in that trial was 63, and they were American women. A lot of them were smokers, a lot of them were overweight significantly, and there were an extra 9 cases per 10,000 women on oral hormone therapy. Again, it's oral hormone therapy, But we also know that the vasomotor symptoms, the severe flushes and sweats, is actually a risk factor for heart disease and stroke in its own right. So there's conflicting sort of evidence there. And this is where this whole area is so tricky for women and their doctors to try and decide how they feel about it. There's no risk of endometrial cancer so long as I said, the progesterone and estrogen balance is right. And then, before I go on to talk about breast cancer, I just want to note that the Women's Health Initiative study trial did show a reduced risk of colorectal cancer in women taking hormone therapy, and this was never talked about. In fact, any positive finding from the Women's Health Initiative study was never discussed. But for some women, that's actually highly relevant. If they've got a family history of lots of people with bowel cancer, that could be something that they want to know. So the point of this slide was to show the trial, the trial finding in women between 50 to 59 years, so the age that we would prescribe hormone therapy. And this is the trial which was estrogen alone, so these were the hysterectomised women, and this is the trial that took estrogen and progesterone. And the point I want to make here is that breast cancer, you can see that in the estrogen alone arm of the trial, there were 5 fewer cases of breast cancer. This was published in 2005, 3 years after the Women's Health Initiative study, to 0 impact around the world. Okay, so estrogen alone actually resulted in lower breast cancer rates. You can see that in the breast cancer part here, there were 6 extra cases per 10,000 women per year of use. So that is a very small absolute risk, but it is there. It didn't seem to accumulate to women who had taken hormones for more than 5 years. But the important thing is that if you look at the all-cause mortality and the all-cancer deaths, they're actually lower. So although 6 extra cases per 10,000 women were diagnosed, they didn't actually die from the breast cancer. And that's important too, because women die from heart disease and dementia. And this slide shows that if you look at kind of the 100% graph, you've got 53% cardiovascular cause of death, and that's the breast cancer, 4%, just up there. So if you get diagnosed with breast cancer in Australia in 2025, you've probably got a 95% 5-year survival rate and about 89% 10-year survival rate. So it's not, I mean, I'm not saying getting breast cancer is a fun thing, but it's probably not going to kill you. So how do we put breast cancer risk into perspective? I think we have to say there is a very small absolute risk, but how does that compare to other things that we do in our lives every day probably without even thinking about it too much? And so this was created again by the British Menopause Society to help women understand this in a graphical way. So if there were 1,000 women aged between 50 to 59 in the UK population, and they are very similar to the Australian population, 23 women would get diagnosed with breast cancer out of that 1,000 women. There would be an additional 4 cases in those women if they took hormone therapy. There would be 4 fewer cases if they were on estrogen alone hormone therapy. This is the contraceptive pill line that nobody ever talks about. So I see women all the time who, have taken the pill for 30 years, but they don't want to take hormone therapy. So there's an extra 4 cases if they're on the pill. An additional 5 cases in women who drink 2 or more standard drinks of alcohol per day, glasses of wine. 3 additional cases in smokers. And the bottom line, an additional 24 cases in women who are overweight or obese. And the bottom the very bottom line, 7 fewer cases in women who are active, physically active, doing exercise 2.5 hours a week, at least. So I think it does help you put it into perspective that, you know, yes, there is a small absolute increase in risk, but you could be feeling a whole lot better and getting all of the preventive health benefits as well, and then more able to actually do all of these things. Do the exercise, keep your weight down, you know, reduce your alcohol, because you feel like yourself. So I think it's a nuanced kind of thing, and at the end of the day, it's just up to each individual woman to decide what she feels happy with. So how long do I take it? And do I have to stop it? I get asked this a lot. Do I have to stop it? So once people are happy, they sort of don't want to stop what makes them happy, I find. So there used to be this myth going around that you had to stop it after 5 years, and I think that came from, as I said, in a Women's Health Initiative study, the breast cancer risk didn't seem to accumulate till people had been taking it for more than 5 years. So I think a whole lot of doctors were just reefing women off their hormone therapy after 5 years. But all of the menopause societies have realised that it's more nuanced than that, and there's not really an arbitrary limit. So the only way of knowing you've got symptoms is to come off it and see if your symptoms return, and that's a bit frustrating, but that is the only way. So long as the benefits of symptom control outweigh the small risks, then there's no arbitrary limit for how long people can stay on hormone therapy. It's individualised. Ideally, they'd be having an annual review of their ongoing need and their risks versus benefits. There might be things that are particularly relevant to that particular woman. Like she might already have osteopenia. I'm pretty reluctant to take people with osteopenia off their hormone therapy because I don't want them to get osteoporosis. And then as women age, we often reduce the dose. We would definitely always be using body-identical hormones in older women. And definitely trying to deliver the estrogen through the skin, ideally. And I meet these women all the time. They missed out on hormone therapy, but they've got severe symptoms, they've been suffering, and they've kind of they've read the tea leaves and they've worked out that women are taking hormones again. And so they think, well, why not me? And I mean, I never say, unless the woman has a lot of risks, I wouldn't say no, don't consider it. But I would be pointing out that the ideal time to commence it is probably less than age 60 in a perfect world, or 65. Some people are pretty fit and healthy these days, so, you know, less than 65 is my, and preferably within 10 years of their final menstrual period. But if they're prepared to accept that they may have slightly more vascular risks starting at older, and they're going to weigh that up against the benefits that they're going to receive in terms of, you know, their symptoms. And if you're getting woken up for 10 times a night and you've been doing it for 30 years, you might actually go, I don't care if if I've got a few vascular risks, I'm going to take it. I mean, I think it should be allowed. I think it should be a decision for the patient, I guess. So long as they're informed and they understand. So shared decision making. What about testosterone? This is controversial at the moment. There's a lot on social media about testosterone. There's a lot that's sort of a bit ahead of the evidence, unfortunately. I do prescribe testosterone, but I like people to be already on their hormone therapy first. I think you've got to have women on the right dose of estrogen and progesterone. And the only studies that have been done are in men or postmenopausal women. So we do not have data on perimenopause yet. There is a big study going on down in Melbourne at the moment looking at perimenopause and bone health and testosterone, but we don't have any data from that. So as long as women understand that if they're trialling it, the studies have really only been in postmenopausal women and have only really proven benefit for libido and not cognition, mood, zest, muscles, all the other things that people are hoping testosterone is going to give them, then I'm fine to do a trial. Even with libido, only about 60% of women respond. So if after, say, 3 to 6 months of testosterone there's no change to the libido, there's no point continuing to take it. Unless you are getting some other benefits from it that, you know, you're convinced are there. And libido is sort of a multifaceted thing really, isn't it? There's lots of things that impact it. So I think you do need to, or the doctor needs to make sure that there aren't other causes for low libido that are the real reason here, and we're hoping for a hormonal solution. You know, if you don't really like the person that you're supposed to be sleeping with, it's probably
not
I could give you, you know, a truck of testosterone. It's probably not going to make much difference. So there are actually prescription medication alternatives to hormone therapy for women that can't take hormone therapy or won't take hormone therapy. So some women just don't want to take it, but they have got bothersome symptoms and they're prepared to try other things. Some women have breast cancer and they can't take it. Most of these have been evaluated for their impact on flushes and sweats, but there's some evidence around mood for some of them. Gabapentin and pregabalin are anti-epileptic drugs. Nearly all of these things are things that are used primarily for another purpose, and we're kind of getting a sort of a benefit with flushes and sweat reduction and maybe some mood benefit. SSRIs or SNRI antidepressants prescribed. Clonidine, not a lot of evidence for that. Lots of side effects potentially, but sometimes, you know, I'll meet women who've tried absolutely every one of these and none of them have worked. So we might try clonidine. That was an old-fashioned blood pressure medication. Oxybutynin is a medication that is used for women with overactive bladder, but we do know that it reduces flushes and sweats. So for some women that can be helpful. And the new kid on the block is Veoza or fezolinetant. This came out of American research and is looking at hot flushes and sweats from a non-hormonal mode of action with the neurological system in the brain. And so it's a neurokinin 3 receptor antagonist, and it blocks neurokinin B in the hypothalamus, which is where flushes and sweats occur. And so we know that at menopause, the relationship between neurokinin B and estrogen is disrupted. And so that's how it works. Liver function has to be monitored. It hasn't been studied in women over 65. And at the moment, we don't have data on breast cancer, but there is a big trial about to be reported on, which will tell us whether it works in women that have had breast cancer, because they're the big ones that usually can't take hormone therapy. I've had a few people try it. I haven't had enough people try it to know what I think about it yet. But it's a new pathway that we can use. So resources, I think this is in your bag. These are all evidence-based places. It is really good to go to evidence-based sources. I'm a doctor, I probably would say that, but I really believe what I say. That's why I put that there. She looks like a hippie, doesn't she? Questions?
I just have an understanding of defining menopause and postmenopausal timeline. So is menopause the 12 months after your final period, is that right?
No. So menopause...
Understanding the timeline for postmenopausal, what do you mean by that?
Yeah, great question. So menopause, it's actually really quite amusing. I don't know who decided this. Menopause is one day in your life, the final period day. You don't know you've had that day until it's gone, but that's menopause, right? And then 12 months later you go, oh, when was my last period? No, you looked at your diary and it was 12 months ago. That's how you know you're post-menopausal, because that's how you know that that day that you didn't know the significance of is menopause. So everything before that day is pre or peri. Everything after that day is post-menopause. So
5 to 7 years that you talked about, is that like from the day you finish your period?
no, it can start in peri. So that 5 to 7
How long can our symptoms
years.
So it's different for every woman?
Every woman. Yeah, and it can go for years for some women, years and years. Yeah. So it can start in peri, and it can go on and on and on and on and on. I've seen that. The average is 5 to 7 years, but you know how you have a bell curve? 5 to 7 years is the middle of the bell curve.
Yeah.
So you're going to have all these women out here that are having a very long experience, and then you're going to have these women here who are having a shorter experience. Yeah. So I always find it funny when, to your question, when people say, oh, I'm post-menopause, I've finished, I'm done. But you're actually post-menopause until you die. So you're not done. Okay, maybe what those women mean is I don't have bothersome symptoms anymore. Maybe that's what they're referring to. But they still need to look after their muscles and bones and heart, and they've still got the effect of no estrogen right through until they die. Yeah. Yes?
I'm really confused.
Oh, that's good. I like to confuse people.
So I haven't had a period since I was 24, between endo and having Mirena my whole life. I've probably had it for 6 months when I had my 13-year-old, and then straight back to Mirena. Had a hysterectomy 6 years ago.
Yeah, 6 or 7
Kept
years.
my ovaries, but only started sort of flushes maybe a year ago. So I have no idea where I'm at.
How old are you, if you don't know?
49.
Yeah. What I would say is it doesn't really matter. You just got to treat your symptoms, you know. So if those symptoms are bothering you, and they may not be, then you would do something about them. But it doesn't really matter whether you're peri or post or whatever. It's a clinical diagnosis. It's not something we do on blood tests. I mean, you could get a blood test done, but I don't know that it's really going to help you. Yeah, I would just be going, well, if you're 49 and that started about a year ago, you're probably somewhere in the perimenopausal transition. You know, you could be post, you could be just post, or you could be just pre. But at the end of the day, it doesn't matter because you haven't got a wound. So if you decided you wanted to take hormones, you just need estrogen. Except if your endometriosis is quite severe, in which case I would argue you should have progesterone as well. Okay. Yes, the lady back table.
I've got a question about if you're taking naturopathic, like really good quality Menopause and those sort of kind of supplements, is that okay to take the hormone replacement as well, or does that interject with those kind of, what's your view on it? Can you do both, for example?
My gut feeling is that you would be able to do both, but I would need to know what those other supplements had in them.
Yeah.
And I would normally be trying to talk to your supplement person, whoever is prescribing those, and try and work together. Yeah.
But it doesn't.
It's not necessarily that you couldn't take both, no. And in fact, there are some supplements that I take, even, much to my shock. You know, so yeah, you can. Yeah. Yes.
Thank you. That was really amazing information. I really enjoyed that. What do you think about having bone density scans to just check where we're at? Is that a thing?
I think it's a great idea. The problem that I have as a doctor is that the government only subsidises the cost of that when you're over 70. Because they wait until they've got the biggest bang for their buck, basically. So, if I see a woman and she has a lot of risk factors for osteoporosis, I will definitely encourage her to self-fund a DEXA scan, but they're not that expensive. Like, I think it's somewhere between, depending on where you go, it's somewhere between $100 and $200, which for some women would be prohibitive. I'm not dismissing that, but 120. Yeah, so, but I was the same as you. I said to I can't even believe I had a personal trainer, but I did have a personal trainer at one point. And I said to him, he was doing his assessment thing, and he said to me, what's your bone density? I said, I don't know. And he said, well, why don't you know? And I said, well, because I'm pretty healthy. I did a lot of sport when I was younger. I've never had an eating disorder. I've got no one in my family with osteoporosis, although I just found out my mother's got it. I said all that, and he said to me, but why don't you just go and check? And I thought, well, yeah, why? So I had to have a personal trainer say to me, why don't you go and get it checked? Because I had in my head, oh, well, I don't need it, And he said, well, you don't know something unless you do it. And I thought, oh my God, that is so true. I can't believe anyway. Yeah. So I would, if you can afford to self-fund, a baseline one. The other person that I try and encourage to have a bone density scan, frequently I meet women who they're a little on the fence about hormone therapy. They're kind of almost there, but they're not quite, and they've got fear. There's a lot of fear about it that came out of that study. And I say, well, why don't you get your bone density checked? And if you've got excellent bone density and you feel your lifestyle stuff is really holding you up well and you're going to do it, you're actually able to do it, then why don't we hold off on the hormones? But if your bone density is osteopenia, you might actually go, well, shitters, I think I'll take the hormone therapy. So I'll sometimes suggest it in that setting too.
Thank you.
Yeah.
Oh, mine.
Yes.
If you've been diagnosed with osteopenia and your doctor didn't recommend hormones, is it time to find another doctor?
Yes.
Yep.
One without a penis.
Yeah.
No, it's because I started hormone therapy, but that actually really doesn't they don't come into the conversation. So I'm listening to you.
Yeah, maybe. Not everybody's that interested in menopause. I mean, look, I feel bad saying it. I think everybody should be interested in menopause, of course. But not every, and I say to my male colleagues, and there's many of them, 51% of your patients are female.
Mm.
You have to learn about menopause. And it still does nothing.
Yeah.
So, I don't know. Yeah. Yes?
Could you just tell us about the bodies identical versus bioidentical?
That confused me too.
Yeah, that confused you? I aim to confuse.
Face, sorry.
No. Okay, so the bioidentical hormones, they're often the same, they're not always, but they're often the same hormone structure that we prescribe, but they're made by compound chemists, and they're put into these things called troches, which get absorbed through the lining of the cheek. Then the patient has all these salivary tests, which are unvalidated, but they're done. They have salivary tests, and then the doctor, and it is a doctor apparently, I don't know where these doctors are training from, maybe they're integrated medicine doctors or something, I don't know. But they then look at the salivary hormone levels and apparently adjust the doses and prescribe it. So it's not really regulated. There are some pharmacies in Melbourne, some compound pharmacists that I've developed a relationship with that I would trust and that I would ring up if I wanted to know what really So I'm not saying all of it's bad, but there's no reason to go to that when you can actually get the exact same hormones in prescription regulated medication delivered, in a way without doing blood tests or saliva tests. I don't know, there's a lot of, it seems so nice, it seems kind of designed for you, designer, it seems designer, but I think it's not regulated, and we've had cases of endometrial cancer happening in women taking bioidenticals because they weren't getting enough progesterone. I've had patients getting a lot of testosterone and getting irreversible side effects. So it's not, I mean, I just think you've got to go in eyes wide open. I'm not saying don't do it, but I'm just saying I can't recommend it, especially when we've got hormones that are prescription grade, hormones that we can prescribe. Yeah, sorry.
Yeah, I was just going to say there's been some really beautiful data out, and we're big concerns because hormones fluctuate so much. So the testing that they do to see where you are to compound those prescriptions means that on some days the woman is getting doses of hormones that are so intrinsically dangerous without realising it. But with what Lorenz talking about prescribing, because of the way that goes into our system, it's so on the days when we don't need massive amounts of that estrogen, we just beautifully digest it. It doesn't affect our organs. So this data was quite
Yes.
I have a question about the breast cancer risk, and I'm wondering if you can there's a lot of assumed knowledge. We all sort of know something about there being a breast cancer risk, but could you actually talk a bit more about what that, because obviously there's a bit of fear, and I'm much more down the natural route, but I am wanting to know a bit more detail about what that breast cancer risk is. Why are people scared? Is there now a reversal? I don't really understand.
Yeah. There's a lot less fear now in the people that understand it. So when the study first came out, that was 23 years ago now, and what ended up happening was that they reanalysed all the data and took out all the young women. So by young I mean 50 to 59, and I showed those women in that slide. So they've reanalysed all of the data, looking at the age of women that we would normally be prescribing hormone therapy to, because the average age of women was 63 in the study, which is quite a bit old. So when they took that group out and reanalysed the data, the absolute risk of breast cancer was there, but it was very, very small. So it was an extra 6 to 8 cases per 10,000 women per year of use. And now when I say extra, I mean above population risk, because we all have, if you believe the latest studies, we've all got, just from being female, a 1 in 7 lifetime risk of getting breast cancer. So when I say an extra 6 to 8 cases per 10,000 women, I mean above that already background risk that we all have. Yeah? It didn't seem to start to become significant until women had taken the hormones for more than 5 years. And so that's where that whole thing about taking people off their hormone therapy came from. And that is using hormones that we no longer prescribe. So we don't prescribe oral estrogen and synthetic progesterone, because that's what that study was. It was conjugated equine estrogens from horse mare's urine and synthetic progesterone. We don't have a randomised controlled trial with the hormones that we do prescribe now, so the natural progesterone and the natural estradiol, but we do have, the French did a very large observational study. So there were 90,000 women in the study, 45,000 women took the hormones, and 45,000 didn't. They looked ahead 9 years, and then they compared the breast cancer rates between the two groups, and they were identical. So there are a number of views around breast cancer risk and hormone therapy. One of them is it the progesterone? Because as I told you with the data, women who had a hysterectomy and didn't take any progesterone, they actually had a lower breast cancer risk. So is it something about synthetic progesterone that was giving the increased risk? Or is it something about the delivery of the estrogen, because we were giving oral estrogens? And so that's what then led to these bioidentical hormones being discovered and invented and kind of produced. So we do think the landscape is a lot safer, but we don't have an equivalent study. And do you know what? I don't think we ever will get one. I don't know if a drug company will pay for it. You know, that study back in 2002 cost over $1 billion. So I just don't know if we're going to get it. But I mean, it was really fantastic that the French did that study that they did. I mean, observational studies are never as good as randomised controlled trial, but when you've got massive numbers like that, I think it's very reassuring. Yeah. But you know, it's an emotional thing for a lot of women, and there was a lot of talk for a lot of years, and there's a lot of damage that needs to be sort of undone, I think. I'm hoping that by the time your daughters and nieces and granddaughters and things, that there'll be less controversy over it. Sorry.
I just wanted to ask about other cancers. So you keep saying breast cancer, but is there evidence of other cancer risk? I've been denied HIV because of the cancer, it's not breast cancer. So I'm wondering what the connection is.
So most ovarian cancers, it's not relevant, but there are some very hormonal ones where it can be. So it depends on whether they're hormone receptor positive cancers. As I said, bowel cancer, there's a lower risk. Endometrial cancer, usually if people have had endometrial cancer, so long as they've had a hysterectomy and they've been, you know, cured and they haven't had like spread, then they can take hormone therapy. So it's really mainly breast cancer. It's breast, but estrogen sensitive cancers or estrogen dependent cancers. But there aren't that many that aren't breast. You know, there's a couple of maybe of the hormonal ovarian cancers. Meningioma in the brain apparently has progesterone receptors, so sometimes those women get told that they can't take hormone therapy. But in my experience, it's usually been breast cancer. Yeah.
It's feeling like that assessment for me was born out of ignorance.
It's hard. Look, I can't comment exactly, but it's possible. Yeah. Yes.
What happens after you're 60? So if you went on HRT and then you got the symptoms you get during your 50s, do they don't get worse? Like you still haven't got any estrogen later in life. So does your body stop muscle atrophy, or it just basically rolls over to old age, so you're going to get deteriorated everywhere anyway?
Great question. Yeah, I've never fully understood why, even though you're still estrogen deficient, you don't get symptoms after a certain period of time, and that's obviously different for different women. I presume it's got something to do with receptor sensitivity and things that we don't understand. But just because you, like I was saying to the lady over here, just because you don't have symptoms doesn't mean that you're not postmenopausal and your muscles are all wasting away and your bones are, are thinning, and you know, you might not feel it, but you might feel great. But there's still things going on in your body as a result of the lack of hormones. Yeah, and then there's ageing on top of it. Yeah.
Apparently the Queen was on MHT until she died, the day she died.
Yeah.
If you're interested in social media, there's a UK medical practitioner who's quite prominent in this space, Louise Newson.
Yes.
Yeah, and she has a lot of good information on that study that you were asking about, and cancer and that kind of stuff. And also about hormones across your lifespan, not just in this period of your life. The menopause doctor, I think, is other social media, but she's quite good. I have found her.
She's great.
Sorry. Yes.
We talk a lot about physical effects, but cognitively, HRT, does that help the brain fog?
Yeah, it does for most women. It takes time.
It is a real thing, brain fog. I feel like my memory is just...
Yeah, no, it's definitely a real thing.
Yeah.
Yeah, it does. It's not. Some women it can improve quite quickly, but other women it just sort of gradually improves. I always set my review at 3 months because if you review too early, you don't get all the effects from the dose. Flushes and sweats and joint symptoms very quickly respond within weeks. But I find brain fog, mood, libido, those sort of things, they're sort of more a slow burn of improvement, gradual improvement.
Because if you don't have the hot flash issues, it's more around the moods and the brain fog.
I see a lot of women for that. A lot of women don't have the flushes. It's more, like I said in that slide.
HRT that can address it over time.
Yeah. Not all menopausal stuff is flushes and sweats, and hormone therapy is used for the whole gamut of symptoms, not just flushes and sweats. Yeah.
Another question about when you say HRT, is it like tailored to my specific blood tests, or am I just taking estrogen?
Yeah,
the
the
same
same.
amount as the next one?
Yeah. Well, maybe not the same amount as the next one. We don't adjust the doses according to blood tests or saliva tests. We adjust the doses according to severity of symptoms and response. So it's a clinical thing. It's a clinical judgment.
Okay, so I guess that's kind of tied in with my question. Do you know much about the Dutch test, and do you do that?
I don't do the Dutch test.
And is that because it's not your area of specialty, or because you don't think it's a good idea?
What is it?
It's a urine. Yeah, look, it's not my area of specialty. Yeah, and I would need to talk to somebody that does it to know whether there's evidence for it or not. But because I was never taught anything about it, so I can't comment. Yeah, sorry.
I understand Dutch test is like quite specific hormone testing that tracks your hormones through your cycle, and also talks about things like estrogen markers and things like that. I think it's been a while since I've listened to a lot of stuff about it. It's to do with the pathways that can take up the estrogen, and that also has some sort of effect on breast cancer risk. So that's why I was wondering about the Dutch test. It's more nuanced.
Yeah, sorry. I don't know.
With regards to, and I hope this might be helpful, just the dose and what different people are on, and I don't even know if this is allowed. Because I'm on the gel, I can adjust my dose as to where my symptoms are at. So if I have a little bit more symptoms, then I might use 2 pumps that day, which I find really, really useful, and I'm assuming that's fine. Just sometimes in a month I'll just have more information, so I'll use 2 pumps for 2 days, and then, so I have more estrogen those days. Yeah. So it's like dose adjustment.
It's fine. Yeah, it is fine. But it is good to just run it by your doctor, because you just always got to make sure you've got the progesterone balance right. Yeah. I had a patient who said to me, I used to take party drugs before I went dancing, but now I just give myself an extra pump of estrogel. And I said, how often do you go dancing?
Yeah.
that's okay. It's probably okay, but like if you're going to dance every night, I might need to adjust your progesterone, right? So as long as you chat with your doctor, it's fine.
So I don't dance every
Yes. So it depends on the patient actually. So some women can take estrogen before bed and just jump in and take their progesterone and go to sleep. Some women, if they do that, they get kind of woken up by the estrogen because it is a very stimulatory thing for the brain, estrogen. So I generally think if you think that you would be, if you're a sensitive unit, which I am, I would take it in the morning and I would take my progesterone at night. Yeah.
And just one last question. What would be the oldest age you would prescribe HRT? I know that you have benefits.
Do you mean to initiate therapy or to continue therapy? It depends on the health and fitness of the woman, because to be fair to some older women, they're often fitter than some of my perimenopausal women. So I take an individualised approach. If I've got a super fit, healthy older lady with very few vascular risks leading an exemplary lifestyle, then I might prescribe very low dose bioidentical hormones to her because I think, well, why shouldn't she get the benefit if she's done all this stuff, looked after herself? You know, surely it's her choice. So that's me. I don't think you'll find that that's a common view. In fact, I know it isn't. But if she had lots and lots of vascular risks and she still really wanted to take it, then I would try and, I probably would try and work with a cardiologist and get all her vascular risk factors under control, maybe add in, you know, like a cholesterol lowering medication or something, and then maybe she can take it. So I'm not saying it's a hard no to every single older person. I just absolutely hate the idea that there's some age where we just cut stuff off at age. I actually had a slide, but I think I skipped over it accidentally, which was probably not. It was probably the slide that I was most interested in talking about, which is menopause and empowerment. This is a huge issue. Genderism, ageism, making workplaces menopause friendly, you know. What are the messages we're giving our daughters, our granddaughters, our nieces, you know, about ageing and about health seeking, you know?
One of my GPs, she loves HRT. Her mother was saying was 90.
Yep.
And then she's gone off it now. I didn't ask the reason, and she's getting Alzheimer's.
Yep.
Yep.
Yeah. Well, one of my good friends says to me she's going to die with her patch on. I'm probably in that camp unless something changes, but I think each woman has to make their own very personal decision, and they have to be flexible with what happens throughout the course of their life. Like, I don't know what's going to happen, but if I've got the chance to take hormone therapy till the day I die, I'm probably going to. Yeah, that's me, but I think, you know, everyone just has to make up their own mind. Yeah. Yeah.
Hello.
Hi.
That was amazing. So thank you. I actually came to saw you a few years ago, and you up to diagnose my PNPD, and I believe I'm in peri at the moment. Anyway, I just wanted to say two things. So first, you know how you said like lifting weights has really helped you? I hate gym, right? And also, I'm not very good at, you know how you like, I need to have everything. So doing it at home is really happy. I got into Pilates, so I just wanted to share that because everyone knows about Pilates, but I found it to be incredible for me. Like,
Yeah.
I've got this beautiful, safe Pilates studio that I go to every day and I feel great. So there's that, but also I've gone up to the Women's Health Clinic in Kyneton recently and been triaged to see Dr. Emma. And the thing that the nurse talked to me about that would probably be suitable for me was Slinda, and you didn't mention it. So I just wondered if, because it's just recently gone onto the PBS, just curious on your thoughts or understanding of that in general.
So, Slender is a progesterone-only contraceptive pill, but it has a type of progesterone that isn't body identical, but it's not androgenic. So it doesn't hit the androgen receptors. And so it can be good for people with mood stuff because it's not androgenic progesterone. I do use Slender in perimenopause, and I didn't actually say it, but in perimenopause, sometimes a low-dose contraceptive pill up until the age of 50 is a good solution.
Well, that
Depending
was actually
depending on the pill though,
Yeah.
it really depends on the pill.
So when I saw you said two things to me. You said Premiula, which I still take, and it's been really good. I also use CBD oil at the moment, because my thing is definitely mood, the PMDD stuff, just very happy, and inflammation. Like my body's always in pain. So yeah, but one of the other things you said was if you want, you can go on to, there was a type of pill that you also wrote down. Yeah, so it's kind of similar to that.
Well, it's similar to that, but it doesn't have any estrogen in it.
Yeah.
But what it's doing, what Slender will do, is stop that ovulation, so you don't get the rise of progesterone in the second half of the cycle. And so then you will hopefully not get the mood stuff. So I do have some patients who are taking Slender, and then as they are approaching menopause, even though I'm adding in low-dose hormone therapy, but that's completely off. There's no trials on that. No one's ever studied it that way. But because we used to have a hormone therapy called Angelique, which had the exact same progesterone in it, combined with estrogen, I kind of think it logically, if we could use that, then we can definitely use Slender as the progesterone component of hormone therapy and then add in the estrogen. And I've got a few patients on that, not many, but yeah, so yeah, Slender could be a good option, but there's no estrogen with that.
Yeah.
Whereas that pill that I wrote down, it would have been one of the body identical low-dose estrogen pills with estrogen and progesterone in it.
Yeah.
Yeah.
Thank you.
Sorry, that wasn't my last question. Before HRT, they do recommend screening on your breast.
Yes.
If you don't want to do the mammogram side of it, wanting to X-rays, what's the next option? What would be the next one?
So do you mind me asking your age?
Yeah, 59.
59.
Ultrasound?
You could do an ultrasound, but it's not going to pick up everything. But there's no radiation. The next best thing is probably breast MRI, but it's very expensive. Yeah, there is. There may something. Do you know anything about that, Danny? No. I don't know a lot about that. The breast surgeons that I work with don't really talk about it, so I've assumed that it's of limited use, but I can't say that I know. So I'd have to, you'd have to find that out somehow. Maybe ring one of the places in Melbourne that does it. Yeah. Yeah.
Everyone else on social media, there's a big thing about cortisone and withdrawing your hormones through cortisone. And I saw on one of your slides you actually had it up. Is there a link?
Yeah, there is a link between high cortisol levels and weight, and insulin resistance and that sort of thing. It's why it can be really difficult for people who are very, very stressed to lose weight, because they've got very high cortisol levels all the time. And it's kind of like, even though they may be making very wonderful choices with exercise and eating, they're kind of fighting that hormonal effect in their body. And people who don't sleep very well have high cortisol levels. And most menopausal women are not sleeping that great. So that's what I mean about weight gain in menopause. It really is quite multifactorial, and it's really hard to tease apart all the different things and work out what you're going to do. It's not easy. That's the one I struggle with the most as a doctor trying to help people. Like, I'll often get them really good symptom-wise, but they're still carrying unwanted weight. So then we've got to think, well, what next, you know? Yeah.
Yeah, I've got, if you've in your life taken, various hormone treatments like pill being probably the most common one, or lots of IVF or things like that, once that's done, is that all out of your system, or is that something that might come back and affect symptoms down the track?
Do you mean breast cancer risk, or do you mean
or menopausal symptoms? Like, could that affect what you might have had otherwise?
Yeah, I don't think it would affect your menopausal symptoms.
Okay.
Breast cancer risk, probably not years down the track. It's probably, there probably is a kind of a minor effect that goes on for a while, but it's not going to be forever.
Okay.
Yeah, so no, it shouldn't change your experience of what menopause is going to be. Yeah.
Good question. Everyone's quiet. Or we've all forgotten.
Anita.